about this?
Just for recording.
Oh, recording. Okay. Call it the Madonna. Very well, thank you.
Backwards, forwards,
It's okay. Well, thank you for the invitation, and the first half of my talk is already finished because Devere just did it. So I'm going to go rather quickly through the evolution of the implants and just review very quickly that there are distinct differences between metal and carbon fiber. And my training is in engineering, so my background is mechanical engineering. And one of the first things I recognized with carbon fiber was that the modulus is much closer to bone. And anything you can do to simulate bone, the body is going to like better. The question was, can we successfully execute carbon fiber clinically? And more importantly, in the past, it was a matter of cost. Everything now comes down to how much does it cost. Not does it perform well, is it better? I don't need a Ferrari, I need a Peugeot. And the hospitals are saying that they don't want to pay for Ferraris anymore, and so we have to now be cost effective. And one of the things that CarboFix has done successfully that other companies have not is they've figured out how to manufacture carbon fiber in a cost-effective fashion. And you can see that another big advantage, and I think he showed this too, is the fatigue properties. Obviously, metal is like a paperclip. In the United States, we would say it's a race between biology and metallurgy. If you can get the bone to heal first, you win. If you can't get the bone to heal, it's just a matter of time before the metal fails. And that's true still today. And I think the limiting factor, even in carbon fiber, is not going to be the carbon fiber implant. It's probably going to be the interface between the implant and the bone. When they do the comparative testing to other companies that are there, what you're seeing is a difference between the technology of the construct of how everything is put together with layers to basically make it an anisotropic material versus an isotropic material which is homogeneous. And in their testing, they found that when you compare it to the other products that are out there, there's clearly advantages because they're able to manufacture it in a fashion that is able to withstand longer cycles. I think you've already seen this. Devere mentioned that you have some potential effects on healing. We have not been able to quantify the effect of healing, but every surgeon that I know who has used this product, who I respect, and who understands engineering, tells me the same thing. And I ask them, how do you describe what you see with carbon fiber? And they say, I can't tell you for sure, but the best way to describe it is better, callus, faster. So we're seeing this callus form in a much earlier stage. You can also, as you saw before, you can see the x-rays. In the past, we couldn't see the x-rays because one of the tricks we would use in trauma, whenever you had a difficult case, is you would put more metal and cover up your mistakes. So the more metal you put, the x-ray wouldn't show what you had behind the metal, and this way you could get away and say, well, it's a difficult case. With carbon fiber, you cannot lie. So you can see everything. So you better do a good job when you do the initial fixation. And you can obviously, the oncologists love this because now they can monitor their treatment, they can radiate, they can do MRIs, they can do CT scans, and you saw the effects of that. So the question is, and this is the first question I had was, well, if you can't see the implant, how do I know when I'm putting a rod, or if I'm doing percutaneous fixation, how do I know where the hole is? Because when you have metal, I can look at the x-ray, I can see the hole, I can put my drill in the hole, and I know the screws in the hole. How do I know where the hole is for the interlocking? So they devised a method where they put markers on the nail longitudinally so you can see the top, you can see the length of the nail, and the real issue now is going to be how do you do the interlocking holes? Because I think I don't know if it's true in other countries, but the biggest problem we have in the United States with the community surgeon, the non-expert traumatologist, is it can take expert 20 seconds to put a screw in. It can take somebody who's not an expert 20 minutes to just put one screw across the holes. Are you any surgeons in the room? Anybody orthopedic surgeons? Anybody sales? And when you see the surgeons in the community and they're trying to put the screws, there's a big spectrum of quality. You have the good surgeons, they can do it very quickly. And then you have other surgeons, you just think, what is so hard about putting a screw in a little hole? And it takes forever. So this is the biggest question, is how do you do this? Well, they put the markers in, and this is how you do the nails. So my first question, I thought, oh, this is going to be very hard. And I was Devere will tell you, I was a little bit skeptical. I'm like, I don't know about this. And he said, trust me, do it 2 or 3 times. It's going to be very, very easy. And he was right. And what they do is this is my drawing, they put 2 markers on each end of the hole. And the whole idea is you have to superimpose the 4 markers that when you look at perpendicular, you have 4 points like this. But when you rotate and you get them superimposed, now 4 points become 2 points. And you can see sequentially as you rotate either the leg or the image, it becomes 2 markers. And these 2 markers, you can even see the outline of the hole. These 2 markers tell you the limits of the nail hole. And you can see if you want to use live fluoro, I don't like live fluoroscopy, it's too much radiation, but you can rotate the live fluoro and do it. I think if you have the handle of the insertion guide, that is perpendicular and parallel to the holes. You can use that as a first estimate. Within 1 or 2 motions of the image intensifier, I can get 2 dots. My partner, he likes to make the room radiate, so he puts his foot on the machine and it's live fluoro. But I think if you really want to be an efficient surgeon, the goal is to try to do all of your intramedullary nailing with less than 1 minute of total fluoroscopy time, if it's possible. And then when you get your nails, when you get your holes superimposed, you can see these are the 2 holes. It's not the same for this hole as this because of the parallax effect. So this is centered over these 2 dots, so it's centered. Even though it's the same angle, the same orientation, you have a little bit of superimposition that's not there because of the divergence of the radiation. But even with this, you can still put the drill in the middle and still be successful. So I'm going to focus more on clinical cases. I think Devere covered the technology very well. I'm going to show just some clinical examples and my experiences. So we had a patient with bilateral femur fractures that came in. We put the rods in. In the U.S., we like to do retrograde nails. It's very easy. It's very quick. And what I noticed is in 2 weeks, you don't see callus like that normally in bilateral high-energy femur fractures. So when we noticed this callus forming so quickly, that's what made me think, what is happening here? And it's probably the modulus of elasticity that is helping. We let the patients get up and walk right away, obviously. So we're seeing better callus faster. This is a 50-year-old man who fell from a truck, segmental unstable fracture. This is very difficult nail, obviously. He has a very big leg. And then, as you know, when you have a femur fracture, there's about a 15% incidence of some type of a soft tissue injury to the knee. And so he had a very unstable knee. Now, in the past, we would get an MRI, and the radiologist would call back and report and say, suboptimal examination, clinical examination required, we cannot visualize ACL, PCL, et cetera, et cetera, et cetera. So it was a waste of time. In this patient, we did, and the radiologist called me and said, hey, what are you using in that femoral fracture? I can see everything. And I said, well, it's carbon fiber. He goes, wow, that's amazing. Now the radiologists are very interested in this because now they can actually tell us that there is a lesion of the PCL, and they can actually do an MRI of the knee successfully. And you can see that the sagittal cuts, the PCL, ACL, they show up very nicely in this patient. You don't see that with metal. And then in 3 weeks, you can see a lot of callus. In 3 months, he's healed. This is a humeral fracture that we did. The humeral nail is a little bit different than the tibia and the femur because it's not cannulated, and so you just have to put it in directly, but it's not very hard. The arm is very easy to manipulate. You can see the end of the nail very nicely, and the humerus is easy to nail, and you don't have to have the exchange tube and so on and so forth. This is an oncological lesion, and you can see that you can see the progression of the healing very nicely. Another one with a distal femur. This is the plate that came out. I have to say this plating system is quite nice. If you've ever used the Synthes LIS system, very, very similar to the LIS. If you're familiar with the LIS, this is going to be very, very familiar to you. And what's nice about this, though, is it's polyaxial. The LIS everything was convergent. With this one, I can put the screws wherever I want. And one thing that Devere didn't mention, and this is I don't know if I can say this or not, but you probably have 2, maybe 3 different attempts at changing your screw before you lose fixation. That's true with the metal polyaxial screws, and it's probably true with carbon fiber because you're making your threads when you put it in. So after the 3rd time, it's very weak. So I would recommend don't do it more than twice. Just pick your trajectory. If you don't like one trajectory, make the 2nd trajectory your last one. And this is remarkable. I mean, in 5 weeks to see callus that robust on the medial side. We were seeing this with LIS, maybe a 6 or 8 weeks, but I think with carbon fiber we're seeing it a little bit earlier. This is a very difficult proximal fracture. This is a young man. He's 40 years old. He fell. Whenever you see a proximal femur fracture in somebody who's less than 60 years of age with this much comminution, you know there's a problem. This is not pathologic. It was a traumatic injury. And I look at this and say, oh, that's not so bad. But when I see this, that's what makes me worry. And this is very deceiving because you would look and say, oh, it looks very good. Let's go ahead and start. But what you don't see is this. And this is very, very, very common in the young people. And so you have to be willing to have a very low threshold to just open it. When you put your screw in, if you look at the skin, when you put your screw in, your incision is going to be right here. So instead of making a small 1 centimeter incision, just make a 4 centimeter incision. You can put the clamp in, you can put a wire. I don't like cables, but we use cerclage wires that basically approximates the bone and allows the nailing to succeed without having everything blow apart. This is the infamous thing that happens when you have a basicervical fracture. This always happens to me. Everything looks beautiful. The nail goes in, the neck separates. It goes in the varus or you have separation. Through the same incision, the anterolateral window, you can just put a Cobb elevator, you pull it in, and it reduces it while you put your pin up, and when you're finished, you don't have the medial overhang of the proximal. What we were taught is you always want the medial neck to be over the calcar. If it's medial to the shaft, it's going to settle and you have no support. Because how do you hold a tomato? Like this or like this, right? You don't hold a tomato like this. You have to hold it like this. So this calcar is a support for the neck, which is being loaded with very high forces. Some unique applications. This is off-label use, so I have to make this admission. Patient with a medial condylar fracture. No plate exists for the medial femoral condyle, except the proximal humeral plate. You take the proximal humeral plate upside down, and now you can plate the medial side of the femur. It fits perfectly. It's a beautiful thing. And this is what it looks like after. Sometimes you get into a situation, this is my mistake. I thought in somebody who's this old, this was a simple spiral fracture. I didn't get a CT scan. Normally we would get a CT scan. If I got a CT scan, I would have recognized that there's probably a crack that comes all the way down in osteopenic bone. There's always that crack you can't see. So I nailed it, and I realized in the middle of the nailing procedure, oh my gosh, now I have an intra-articular fracture. What do I do? I've already committed myself to a nail, took the nail out, and then you can see I already have the blocking screw up there. So I use a distal fibular plate with fixation of the sagittal split to now make the intra-articular fracture a type A fracture, and then we can go ahead and proceed with a nail without having to worry. And you can see that what we did is we treated the intra-articular component with a screw and a plate, and we treated the diaphyseal component with a retrograde nail. So mixing the different implant types is possible. Case like this, obviously this was done sometime in the 20th century. We don't do this anymore. This was done in 1994. Patient had a DCS placed and then had his intertrochanteric fracture. So some people would say, okay, no problem. Just put a rod. Take out the screws, do a little bit of overlap, no problem. That's okay, but now you have interlocking issues. What if you can't get the interlock? You have, if you put the nail short, you have stress risers, possibility for fractures. So in this case, we said, look, you don't need the plate. We take out the plate, we use our cerclage technique, put the rod down. But when we get down here, one of the problems with taking all those screws out, I went to put the interlocking screw in, and guess what? It's the same hole of the plate, and there's no stability. And now I'm worried about fracture propagation and stability. So what we did is we used a plate as a washer. The plate holes match the nails holes. So I put the drill holes in of the nail first. Then I took the plate, put it over the drill. So now the plate matches. Then we put the plate to the bone with a regular screw. And then we finish by putting the interlocking screws, and then we also stabilize and protect the distal femur against any further fracture. So unusual technique. Maybe we can use a small, short distal femoral plate next time. This is one of my patients. I live near the mountains, and when you live in the mountains, the patients they don't like to go to the doctor. They don't trust the government. They don't trust the doctor. They don't trust anybody. So he's obviously not a very healthy patient. Heavy smoking, diabetes, neuropathy, no pain, simple fracture. And I said, you know, we can treat this non-operatively. Your skin is bad, your health is bad, your risk is high. If we do surgery, you can lose your leg. So I said, let's just put you in a splint cast, stay off of it for 2 months, everything is fine. Obviously, the patient doesn't listen, walks, comes into the office, but no pain. No pain. No pain. I'm like, don't walk on it. It doesn't hurt. Comes back. He says, it doesn't hurt, but it doesn't look right. His foot is this way now. I'm like, okay, come on, we have to fix it now. So obviously, there's no choice but to do a arthrodesis. So we go in and do an arthrodesis. My technique is I like the lateral approach. I use the fibula as a autograft. So we put the nail, make a cut, autograft, a little bit of bone graft. This time he says, doctor, I will listen to you. And he comes back in 6 weeks, and you can see that he's beginning to heal. And at 3 months, I let him walk, and he went on to heal. Fortunately, he's very happy. Now he has his leg. He can smoke and eat all his candy now. This is an unusual case of an infection. The patient had a 3B fracture, initially treated with an external fixator, then went on to have a rod put in by one of my colleagues. Rod became infected, has a non-union, and one of the problems now is I can put him in an external fixator forever. I can do bone transport. He doesn't want bone transport. In the U.S., I did a lot of bone transport in the past. Now, our patients do not tolerate Ilizarov and bone transport. I love external fixation. It's my favorite procedure. I think it's one of the best techniques we have, but our patients do not tolerate it. They go crazy. The office doesn't like it. They get mad at me because the patients are calling every day. So in the U.S., we are getting away from external fixation. So we went to use a rod. It's a 10-millimeter rod. We put antibiotic around it. We put the rod in. And what you can see is you can actually see the cement around the rod, and you can monitor the healing that goes on over time. And we let the patient walk, and he goes on to heal. This one was my interest is osteomyelitis, so I trained and I'm colleagues with George Ziran, who died 2 years ago. He was the Ziran-Mader classification is what we use. We call him the godfather of osteomyelitis in the United States. This patient came. He's a young man who was a heroin addict. I don't know if you can see, but this was his CT scan. He had no evidence of infection, but a small pustule in the leg, very small, no cellulitis, no swelling. His entire femur, his entire normal femur was sequestrum. His entire new femur is involucrum. You can see this is involucrum, this is sequestrum. So this is the old femur, this is the new femur. This has been going on for years. So the only treatment is amputation. But he said, no, please try one time. He had 3 or 4 draining sinuses. Old femur, which is dead. New femur, which is involucrum. And one of the things that Ziran said is you don't have to remove the involucrum if it's bleeding. It's living, it has blood flow, you can leave it. So this is what we did. You can see the sinus here, sinus here, sinus here, sinus here. This is all involucrum. So what we do is we open it up and we put a saucerization, but by the time we open the femur, it's destabilized. So obviously we take out the middle, you leave only the shell. The shell has a lot of mechanically destabilizing areas. So now we have to neutralize and protect the femur. So what we do is we put a rod, antibiotics, powder antibiotic beads. We have the rod that goes inside surrounded with antibiotic cement, and we put beads in as well, but at least now we can monitor his healing. This was a very difficult case. She's very obese. She is a older lady, motor vehicle crash. Again, this is whenever I see this, I get nervous because this is very difficult. The basicervical fractures and the 2-part intertrochanteric fractures with this. With her, we had to use every trick. We used the medialization. You can see we use the reamer. This is something I do that we published. Whenever you have a fracture that comes out of the greater trochanteric area, when you do normal reaming, the reamer is going to be lateralized. You're going to preferentially ream the lateral part of the proximal femur. So when you put your nail down, what's going to happen is it's going to push this part, which hasn't reamed, and it's going to separate them. So the technique we did is we have to get a concave retractor. We use, we call it a Richardson or a Meyerding, and the concavity of the retractor catches the reamer shaft as it's spinning and pushes it medially, so you create a path for the nail to allow the fracture to reduce. And once the nail comes in, still causes a little bit of separation, but you can see now we release the traction and we do compression, a little bit of compression, and over here full compression, and we reduce the fracture nicely. Then we have another problem. We have the distal fragment, which is unstable, and so we use the polar pin, and you can see the nail here. I don't know if you can see those 4 dots, but this is the nail going down, and it's approaching the polar pin. As it passes the polar pin, you can see how the fracture now reduces and works nicely, and then in the end, we have a reasonable outcome. So, in summary, as Devere said, they have a lot of different implants. I think the strength of the technology is the intramedullary techniques and the periarticular fractures. The only negative thing I can say is when you are used to metal that you have to bend. For example, when you have to make a wave plate, or if you have a deformity that you can take metal and bend, you can't bend carbon fiber. The bone is going to match the plate. So don't try to plate a crooked bone, because the bone is going to fit the carbon fiber. But for intramedullary nailing, for the tibia, the humerus, the femur, the hip, and the periarticular fractures where you want that shape, the technology works very, very well. Any questions? That's all I have. Maybe now we have another surgeon talking about oncology.